Good morning, Kirsten. Thank you so much for taking the time to join me for a conversation about the impact of COVID-19 on people who use drugs. Can you start off by introducing yourself and telling us where you are in the world and what you do for a job?
Good morning, and thank you very much for having me on. It's nice to be invited. I have to say it's probably the first time I've put makeup on in like 4 weeks, and it has been noted to me by my colleagues so far this morning, so I've tried to make myself a bit more presentable than usual.
But you're still in your trackies.
I know, I've worn gym clothes for like 4 weeks and never done any gym activity, so there we go. So yeah, I work for Scottish Drugs Forum. I've been there with the organisation for almost 8 years now. And when I initially joined, my primary job was all about the naloxone programme, and just recently, over the last couple of years, that's changed to expand to a much broader remit about everything to do with drug-related deaths. But I still do coordinate Scotland's National Naloxone Programme. So I'm in Glasgow now. I'm not from Glasgow. My accent's a bit warped, and this is me trying to put on my poshest accent so that your viewers can understand what I'm saying. And I'm just in my flat, and we've already had the discussion that I feel like I've gone through a military operation to silence the puppy in the background.
Excellent. Well, I can't hear a puppy, so it's all good. So yeah, so for people who know you, they will see you as naloxone superwoman who really kind of pushed naloxone out across Scotland. And I think the rest of the UK looks at how Scotland has implemented that with a bit of jealousy. So it's a bit of a shame we couldn't have cloned you much earlier. But I guess it's a really good place to start, because unfortunately, despite that amazing work, Scotland has the highest rate of drug-related mortality in Europe. And I guess the first question I want to ask you is kind of related to that, which is, so far, and today is April the 23rd, 2020, what's been the impact of COVID-19 on people who use alcohol and other drugs in Scotland?
Okay, thanks. So yeah, that's kind of you to say about the naloxone programme. It's definitely a team effort. So yeah, something that's been really well recognised across the world. And sometimes, like you mentioned, some of the criticism about the naloxone programme has been because our escalating numbers of drug-related deaths. Well, if you have this fantastic naloxone programme, why is it then that your drug deaths continue to rise? But actually, if we hadn't had naloxone available, those drug deaths would have been way higher, and you know, they are exponential as it is. So you're right that Scotland's rates of drug deaths have continued to rise. The last recorded year that we have for 2018, 1,187 people lost their lives. And we always need to remember that those deaths are overdose deaths only, so they're not deaths from any other drug-related causes, bacterial infections, bloodborne viruses or anything. So on the whole, they are preventable, which is pretty horrific. So no one could have imagined that we would be facing a dual public health emergency. So we already have a massive issue with the drug deaths crisis, and then COVID comes along. And obviously, you know, we can't deny that that is going to have a huge impact on this population. So what we're hearing just now is just anecdotal stuff. So it's really difficult to get a picture of what's happening around the drug-related death side of that. We're hearing more cases in some areas of near fatal overdoses. But yeah, just trying to get a picture of that is quite difficult, and obviously it may be some time before we actually see what the impact has been regarding the drug deaths and the implications with COVID, and I'm sure we'll talk more about that.
Do you think there's been a decline in access to heroin or the purity of heroin, and that's leading to displacement to prescription opioids? Or yeah, I mean, anything around drug supply and drug purity?
I think it's variable. We're hearing different reports in different areas. We're certainly hearing that in some areas there has been a shortage and that prices have increased. In other areas, we're hearing that the drug supply is still very much available. One of the interesting things that we're hearing is that, and I'm sure we'll go on to talk about opioid substitution therapy and how that's been managed, but for people who've been given more take-home doses, it has potentially limited their access to, or you know, bumping into dealers when they go to the chemist. So it's potentially in some populations of people managed their benzodiazepine usage. And we did hear for a while that there was a shortage in some of the benzo availability, and that people were switching to alcohol and using other prescription drugs as well. So I think it's just so variable that it's difficult to get a clear picture on exactly what's happening.
But no one's yet mentioned the idea that physical distancing and people no longer having to go to the chemist might actually mean they're just no longer bumping into dealers who would, of course, target those areas for potential customers. So that perversely is almost a positive, maybe.
Yeah, for sure. It was something that we heard from our colleagues working in homelessness services, because there's been a lot of activity going on to get people who are homeless and roofless into hotels in some of the major cities, in Edinburgh and Glasgow. And so for a lot of those people, they have been given weekly methadone prescriptions, and they've had support from like the Simon community staff. And it was the Simon community staff who I heard talking about this the other day that had said that that was one of the outcomes that some of their clients were mentioning, that they weren't having to go to the chemist, so it was limiting their opportunities to bump into people, and that was making their drug use more manageable in those circumstances.
I mean, displacement from either heroin or benzodiazepines to alcohol has a whole bunch of problems. Obviously, alcohol reduces your immune system, makes you more vulnerable to respiratory infections, but obviously also gives you an added risk of overdose. What's been the treatment and policy response, other than trying to loosen up the provision of methadone and buprenorphine to try and reduce that risk?
Yeah, so again, probably a bit variable. At the start of this, Scottish Drugs Forum communicated with Scottish Government about putting together some guidance on contingency planning, and we put out a document basically reminding people about the importance of prioritising opioid substitution therapy, injecting equipment, etc. And about loosening up the restrictions, because typically Scotland is quite restrictive when it comes to take-home supplies of controlled drugs like methadone. And a crisis like this highlights that even more. So it is quite a culture shift in services and for prescribers to then be loosening up on some of those restrictions. And I think, you know, that's probably a bit of a failure about the way that we deliver methadone treatment and opioid substitution therapy in general, because people are often at the chemist every single day receiving supervised prescriptions. So even that loosening up of that supervision has been quite a challenge, I think, for some areas. But we've seen some excellent examples of good emerging practice coming from it. So more home visits to people who are socially isolating, people being started on prescriptions in their home environment, home deliveries of methadone in some circumstances. So that's been really positive. And I think what this has shown is that whilst it's an absolutely terrible and awful situation, there have been some emerging practices that we would definitely like to see maintained when things go back to some degree of normality. And this should now be the new norm, that we are loosening up on some of this.
I'm going to play devil's advocate here. At a time where people may have reduced access to heroin and other illicit depressants, but there is more methadone available in the community, is there also not the risk that there may be diversion to relatively less tolerant people, and then there may actually be an increased risk of overdose as a result of more methadone? I know it's a difficult balance, but...
No, it is a difficult balance, you're right, but I think less diversion would happen if we had more people in treatment that need to be in treatment. So that is a risk, that is a potential risk of that happening for sure. There's also a potential risk because people have not been used to having take home doses for a week. There is a risk that, you know, this is such a difficult time for people. They might be isolated, their mental health might not be great. There is the temptation then to use more if people have more access to methadone than they normally would have. So that is a risk. But I think that is why we need to absolutely push that anyone who is needing treatment should have easy access to treatment. It should be really swift to get into that treatment. So we've done a lot of work in Scotland over the last while to try and push the idea of same-day prescribing. That's essential just now, that people can have access to that. So the more people we have in treatment, the less likely there would be the need for diversion. So that's something that we're continually trying to address.
Yeah, no, I think that's a really good point. Are you seeing more people wanting to get into treatment?
We've heard certainly in some areas that that there has been more of an uptake from people that have maybe not been seen in services before, or that have been dropped out of services for quite a long time, now re-accessing services. So that's been positive. We've also though heard of some difficulties in other areas of people accessing these services. So it's a real variable picture. So in one area you might be able to get that quick same day access to prescribing, and it'll be a quite easy process. In another area there might be quite a lot of loops for you to go through. We know that we've had various conversations with other organisations, so Scottish Families do a lot of telephone support with people. They've had a lot of issues regarding prescriptions coming through their channels. We've certainly had people phoning SDF in a bit of distress about how to access their prescriptions, and it can be quite a clunky process of different phone numbers. You phone a number, you're asked to phone another number, so that's not great. So there are definitely improvements that still need to be made to make it more accessible. So we've been working on a service directory with We Are With You, formerly AdAction, to get some real-time service information so that we can have that available on a map for people so that they know the exact operating hours of different services and how to get in touch.
I mean, you raise a really important issue that it's not just requiring time for prescribers and treatment services to adjust to a new culture, but also for people in treatment to suddenly go, oh, I don't have to go to the chemist every day. I have to be responsible for my methadone and look after it. And it's going to take time, I think, for people to embrace that change in a way that is positive for them while reducing risks to the community. Policy doesn't change behavior. It's culture, it's conversations, it's people getting used to doing things different.
Yeah, and I think there was a lot of anxiety from people who knew that folk were going to have 7-day supplies with them. People have been given locked boxes and stuff to manage that. There are still some people who are required to go into the chemist sometimes every day, or maybe on a more frequent basis, and they would be deemed to be people who were more of a risk. So that has still been happening in some areas. But I think what also has been reported is that actually giving people that responsibility to deal with their medication has been really positive as well. And we should be more trusting of people. Yeah, like people are adults. We have to give a bit as well, so people can manage their medications when they're given that responsibility. So I would like to see that be one of the sticking things when we go back to normal business or normal-ish business, but the fear obviously is that then the old practices would return.
I'm wondering whether you've adapted your naloxone training and the amount of naloxone that you're issuing, given that there is a possibility that there may be more people overdosing on methadone as a longer-acting opiate, and that the normal naloxone response isn't going to be seen. Has that been looked at?
So we haven't changed the naloxone training or the naloxone guidance. The uptake of naloxone has been a lot larger. So a lot of services are really pushing the naloxone provision. People have moved to postal naloxone services in a lot of areas. So people are able to have naloxone sent to them. They maybe do a quick telephone conversation just if somebody hasn't had training before. So that's been really positive, and that's been an excellent way to get more access to people. There's been home deliveries of naloxone, etc. as well. So the provision of naloxone has been excellent during this time, I would say. So that's a really positive point. On the issue of overdoses where methadone's concerned, we wouldn't change the guidance about how many doses of naloxone to administer. It would be the same. What some people though have been doing, I know that people have been given bigger doses of naloxone just because of the being in the close proximity of somebody that potentially has COVID symptoms as well. I haven't really had any discussions with any clinical folks around this, but I'm slightly anxious about that, because the last thing that we want is people coming round in severe withdrawals and then coughing, spluttering. It's a fine balance between, being there and being in close proximity of somebody who is overdosing. You have to be to save somebody's life. Obviously, we would hope that people would have protective equipment and be able to manage that situation and put themselves at less risk of responding. But at the same time, if somebody comes around in significant withdrawals from receiving a large dose of naloxone, I think we should proceed with caution around that, and it's certainly something that we should look into a bit more.
Yeah, I just hadn't thought about the coughing and the spluttering being yet another risk. So I love the idea of postal naloxone. I love the idea of supporting people over the phone. Have you guys created any short video resources that we could direct people to about how to use naloxone? And we could make a link to it at the end.
Yeah, that would be great. So what we've done, we've had it quite available for some time. We've got an e-learning course that's really thorough for people who have access, obviously, to internet. It's an excellent resource to link into. It probably only takes maximum half an hour to complete. I can certainly share the link for the e-learning course, and that covers everything regarding drug-related deaths, overdose prevention, intervention, and naloxone that you would need to know. We're updating that to include some information on intranasal naloxone. Hasn't been something that's been widely provided across Scotland, but it is something now that a lot of areas are introducing as part of their naloxone programme. So we're going to include intranasal naloxone on there as well.
Excellent. No, so that we'll have a link to that at the end of this video. So you've spoken about a few of the things that you would like to see change longer term as a result. So loosening up of, prescribing, more responsibility for individuals. I want to get your view on telehealth. So some groups have said that this is a very positive thing because it reduces barriers of stigma and having to make your appointment. Other groups have said that for some people, where trust in a therapeutic relationship is really difficult, without that face-to-face contact, they fear that being reliant on a video screen is actually going to be less engaging. What are your thoughts on how we can move forward with telehealth?
Well, I think, and a lot of reports that we've had in have been around people getting more contact with their worker during these times, because a lot of people have, maybe not telehealth, but telephone calls. People have been calling their clients more frequently, particularly people who would be probably needing more face-to-face contact in normal circumstances. And people have been reporting on that positively and saying that that's actually been really useful for them and they've enjoyed that. But I don't think we could ever sacrifice face-to-face conversations with people in that sense of connection. But I think if we can use technology during this time to support people more readily, then I think it's a positive. Had you had any particular thoughts on that yourself that you were?
No, I mean, I listen, I reckon I could probably do 80% of what I do remotely, but I think it would work best for people I've already worked with. I think it's very difficult. I think most of us make an awful lot of judgment about the person who's going to treat us, in that first 2 or 3 seconds, body language, voice, do they look like a twat, whatever it is. And although I'm sure you can make that judgment over a screen, I think it's probably easier to reverse face-to-face. So I think it's about having both. And I think it's about saying to people, if you'd like to come in for a review, that's fine. But we're happy to check up with you as someone who's doing stable and doing well in the community on a video conference. I mean, I think we give people choice and freedom.
I absolutely agree. And I think we've been pretty bad for lots of did not attends, DNAs constantly in our services. And, sometimes it is just not convenient for people to come to our services. The area that I used to work in is quite a rural area, people like a really huge geographical area, even though it was small numbers of people. So getting to appointments was really difficult. Public transport's really difficult for people. People's lives are not always, conducive to attending set time appointments. So I think if we can use technology to better engage with people and give people that choice, I think, definitely a positive.
For people, particularly in remote and rural areas where distance is probably the biggest barrier to them engaging in treatment, it's like, why were we not already doing this? Yeah, I don't think anyone answers that. The fact all of this technology has been around for 5 years, but people have gone, no, we have to see patients. It's like, no, you don't. Anyway, that's some of the benefits. So, easier access, better engagement, loosening up of provisions. Anything else on your wish list for Scotland that might change as a result of this?
Well, there's also been quite a lot of work done to introduce postal injecting equipment. So that'll be like, and I think We Are With You are developing a click and collect service, but there will also be a lot of postal deliveries happening in different areas. I think that is essential. This has also highlighted for me the lack of vending machines that we have in Scotland. So if we had dispensing machines, that would have been a perfect opportunity for people to be able to access injecting equipment without having to go to a pharmacy. So a lot of our pharmacies had reduced hours because of this. People were queuing to get into pharmacies and still are. But obviously if somebody's desperate to get injecting equipment, they're not going to stand and wait in a queue. Now, in the midst of, we also have an HIV epidemic in Glasgow City, and that has spilled over to other areas as well. Other areas are seeing cases of HIV. The concern is that if people aren't accessing enough injecting equipment, are they going to be sharing more equipment? We're not doing, services are not doing bloodborne virus testing at the minute. Are we missing then a huge number of new cases? So this is all very concerning. So I think IEP provision, postal service, click and collect, vending machines, that sort of thing is essential going forward. The vending machine thing, I don't know if that'll happen in Scotland, but certainly the postal stuff will be.
I mean, it is bizarre. I mean, illicit drug dealing networks have successfully been using WhatsApp home delivery and the darknet DHL postal services for the last 5 years. It wouldn't have taken very much for treatment services to go, we could be doing all of that as well.
Yeah.
And it is bizarre how, the crisis opens up opportunity where you think outside the box.
Yeah.
I think what's going to be really difficult, because I think a lot of the changes you've spoken about are going to happen, but I think it's people who've been involved in those guidelines and advising governments are going to have to look back and say, why couldn't we look at this differently in years gone by? When it was very clear there were advocacy groups and other groups who were saying, you can do this differently. Mm-hmm. We're going, our guidelines, this is what they say. They're there based on evidence. And evidence kind of needs to match the culture and the environment. And everything has changed.
I'm a huge fan of the guidance that they've put together in Canada, in BC, British Columbia, for safe supply. And, I think that during this crisis, it's essential. I'm an avid listener to the Crackdown podcast, and just hearing how that's going is something I think we can all learn from. We've had significant concerns about people having reduced access to benzodiazepines because we have a big itizolam issue in Scotland. And if people are getting less itizolam access, are we putting people at risk of having significant withdrawals from benzos? And we need to seriously have a look at prescribing benzodiazepines, a safe supply of benzos that would allow people to, whether that's as a reducing regime or maintenance for some people, should be considered. I definitely think that that's something that we need to look at. It's something that SDF has been keen to put in our updated guidance. I know there will be some resistance to that.
I was going to say, I think it's easier to get doctors to start giving large doses of unsupervised methadone than it is for them to start scripting benzos. Mm-hmm. Like there's a raft of evidence that you can put forward to challenge that, but withdrawal from benzos is potentially life-threatening, and then you get people drinking, and I mean, that's going to be a challenge. I think I'm going to go and find someone to talk about benzos, and we'll talk to someone from British Columbia next week.
That'd be great.
I think this is where we can learn from things around the world. Right, so I'm really pleased. Your puppy hasn't woken up, which is really good.
That's asleep. It's amazing.
Is there anything else that you'd like to share with people before we go?
Let me just check my list.
I could see you looking. I'm thinking, okay.
I had a few things jotted down so that I didn't forget to say anything. I think we've probably pretty much covered most of the things I wanted to discuss. Obviously, we had a letter go out from the Public Health Minister and the Chief Medical Officer recently, just to remind services that they should be maintaining normal service provision during this time. I mean, not normal service provision, but certainly staffing, and that staff from drug services shouldn't be getting deployed to other services, because we had heard that had been happening. So that note was really welcome. And probably just a couple of updates on naloxone as well. So Scottish Drugs Forum was given some funding by Scottish Government to purchase naloxone kits to develop new ways of working. So we've been looking at doing some work with the prison service to introduce intranasal naloxone, because we know that the prison service have been looking at doing early releases. If we can link up intranasal naloxone provision to those early releases, that would be fantastic. But the purpose of making it intranasal naloxone was so that we could provide it to people the evening before they leave, along with all their other discharge medications, because we've continually had this issue of naloxone not being in people's property when they actually leave prison. So if that can be as a small pilot, just to see if that would make a significant shift in the numbers of people leaving prison with naloxone, then that would be good. We're also just about to receive guidance, a sort of comfort letter, hopefully, from the Lord Advocate to allow us to get non-drug treatment services to supply naloxone kits. So, you know, traditionally it's always been the regulations state you have to be a drug service to supply it. That stops homelessness services, family services and others from being able to supply it more readily. So we hope that that'll be in place in the next couple of days so that we can progress some of that work as well. So that's positive. So I guess in the face of lots of negative things happening and you know, our real serious concerns, we are seeing some levels of innovative practice and changes that we hope will stick in the future.
And save lives.
Absolutely.
So thank you. And on behalf of the thousands of people whose lives you must have saved over the last 10 years, I'll say thank you as well for pushing out naloxone across Scotland and showing so many other countries that you can do it. Yeah, which is amazing.
Yeah, we're very proud of Scotland's naloxone programme and all the people that work really hard every day, and for all those people who are administering naloxone every single day to save lives. It's just amazing.
Yeah. Stay safe. Hope your dog wakes up shortly, and yeah, we'll talk to you soon. Thanks so much.
Thanks, Adam.
Take care.
Cheers.
Just taking it one day at a time. Still don't know what I'm trying to find. Really I don't mind, cause I'll be fine. Yeah, I'll be fine. Yeah, no longer focused on yesterday, and I don't care, the rest will say whatever they want. What's left to say? What's left to say?